Hey Mo,
Hey, Ricky.
how are you?
Magical.
In my neighborhood. We're not together, but you're close to me.
It's true. It's true. We're in DC. We're getting ready to really dive into some policy issues here at the Congressional Black Caucus at their legislative conference. And guess what? The doctor is in. Here we are.
The doctor is in, and who else could we have on this in this conversation but our buddy Z, who is like in the trenches? Because tomorrow on our panel we're talking about navigation, and
Mhm.
and Z's here from Oakland. We love you so much, Z, but she always keeps it real and breaks it down to the people. And I think one of the most things I say about you all the time, Z, when I talk to people, is one of the things you taught me like years ago was when you start with a patient, talking to a new patient, you start with, what'd you eat today? Do you have a place to sleep? Where are your kids? And you totally triage their life before you can even get to start talking about chemo and radiation and all the stuff. And that I repeat that all the time about how, we're dealing with so much more than just the cancer. What does navigation really mean,
I think that's a great place to start, Ricky. And Z, we're gonna let you just talk because we think of it. I break it up in pieces and chunks, but it's not broken up like that in real life, And so I think we'll just tell us your story because there's some people who are watching who maybe don't even know who you are and what you're about.
And what navigation really is.
Wow. Well, before I do any of that, I want to thank God first for you, for the opportunity, and for the purpose, because I believe this is his purpose.
It's our God jobs.
Our God jobs, and I just want to, first of all, give him all glory, honor, and praise for that, and for you and this opportunity. He presented you as a blessing, and every time I'm in your presence, I receive you as a blessing. And I just want to say thank you to both of you for that.
Thank you. Well, I forgot to say, tomorrow is my 12-year life anniversary.
Wow. Thank you, God.
Yeah, thank you, God. So
Ricky, hallelujah.
Yep.
My name is Zhonnet, Zhonnet Harper. Everybody calls me Z. I'm from Oakland, California. I'm an Oakland, California native. I'm 60 years old. I still reside in Oakland, California. For the last, it will be 11 years, I have been a patient navigator for cancer, breast cancer specifically. I'm a non-clinical navigator, which means I don't write prescriptions. I don't make referrals into radiation. I don't do any of those things. I'm the support to the patient as they undergo that part of the journey. And doing this work, first of all, I didn't ever want to work for a hospital. I'm gonna just put that out there. I'm in this profession right now due to the economic downturn of 2008. The job that I held prior to that, I worked for a traditional community-based organization, but we dealt with issues of reentry, homelessness, economic development, workforce development, all the additional plagues in our communities. And I did that. I worked with an organization for almost 15 years doing that type of work, and it was a blessing. I loved it. And got laid off, ran through my savings. I did what so many other people do, wound up myself having to receive aid, meaning I wound up having to get food stamps. I wound up on Medi-Cal. I wound up in the place that so many of our patients are now. That was my very first introduction into the healthcare system as somebody without, or somebody looked upon as less than, or somebody who was met with the stereotype as quick as the greeting. That was my very first time, because I came from a more professionalized rank in which there were different assumptions made. Oh, you have this insurance, so that must mean you have a job. If you have a job, that must mean you can pay this share of costs. So it was a whole different world. And that's what struck me initially, like, what the, how I go from having a healthcare insurance that provides and has these assumptions into going into a system where they have all the stereotypes. So you have the stereotypical and the assumption existing in two worlds. That's what struck me first. So, okay, we're gonna get this straight right now. And
Wow.
that's what we did. That's what I did. And then it was the grace of God, because the same hospital that I was getting treated at, which my primary care provider and those that worked with him were excellent. They are the ones who referred me to the job I have now. The same place where I was getting treated is the same place that I have a job right now and have held the job for 11 years.
Wow.
You're kidding.
No, I'm not. That's real.
Wow.
I work for a safety net integrated hospital system. That's just a nice way of saying those that are economically disadvantaged or dispossessed. And what I started seeing, first off, I knew nothing about cancer at all. And beyond learning the medical terminology or trying to understand, the clinical side as to, what happens after diagnosis and what BI-RADS 2 versus 1 means. Besides learning all of that, what I came to understand is I was dealing with my same population. It was just the flip side of the same coin. So many of these people were dispossessed. So many of these people, they were struggling every day. Some of our patients were reentry. We had women that were coming to breast clinic coming straight from a women's, facility,
Wow.
an inmate, right? Basically. And the commonality, the shared dispossession, it was no different for my cancer patient than it was for oftentimes the reentry patient or the single mother or the struggling parent, the struggling family, from when I worked at a previous CBO, when I worked at a different organization. And then the more I got to work with my cancer patients, the more I began to see that it was the poverty and the hopelessness and the struggle that presented the biggest barriers of care. The
Wow.
breast clinic, that's gonna be there. Imaging, that's gonna be there. Radiation, that's gonna be there. Infusion, all that's there, that's set. Okay, there was no variance as to whether those places will be there. The variance and the problem, excuse me, y'all, is can our patients get there?
Mm.
And if they could get there, would they be supported once they got there? How would they be sustained? How would their families be sustained? And so that became the primary focus. And I was very blessed at that time because the manager of our program, and I just got to call her name, Ellen Reinhardt, was fantastic. And this was something we were able to really tackle together. And we really kind of shifted the focus from being clinical. We made clinical where we were in support of care coordination, but our primary responsibility at that point became the patient's burden. Because at the end of the day, if you're hungry, if you have a job that don't want to pay you when you take off, or they give you 2-3 hours, every quarter for sick leave, then that's going to come secondary. I don't think people understand in the higher echelons that oftentimes treatment is a luxury that most can't afford and many don't get paid for.
Whoa. Well, okay, we got to stop and just
Treatment
unpack
is a
some of this,
luxury. Oh my God.
because one, you're right, and two, ouch. Go back to the barrier to care being hopelessness, being some of these other issues, because so often we paint the picture of the barriers to care, in the halls of the medical establishment, which there are barriers there. There are barriers to even, getting prescribed the treatment that you might need that might be life-saving. But talk a little bit more about some of these issues surrounding hopelessness, and maybe some of the ways where people were able to, like, how do you intervene in hopelessness? How do you fix hopelessness?
The thing is, I wish I had that answer, because hopelessness is not a compound word. It could be a series of events. It could be multiple things at one time. You could be hopeless because you're sick. You could be hopeless because you have a job that pays minimum wage and you have no adequate health benefits.
Right.
You could be hopeless because you're worried about your child and you can't help your baby with their homework because you have chemo brain and nobody else is there. Now your child is failing in school. You could be hopelessness is a composition of many things that can happen at the same time. So I don't know that there's a way to fix hopelessness other than to take it on head on. That's the only way I know how to deal with it, is to take it on head on. And it's not that you can provide the answers all the time, but you can try to provide the effort. And whether that effort be in working to try to find a place that supports them in their housing. And I hate calling it housing insecurity. I live in California, honey. We all housing insecure. How high as everything is, okay? I'm talking about in housing, making sure that they have permanent housing. They have affordable housing. They have clean housing. They have housing that is in a walkable neighborhood. See, all of these things, when you're sick and you go into an area that's not being maintained, trash strewn all over the place, no services, all of that plays into the mental, because you have nowhere to look that's hopeful.
But you know what? I believe that can cause breast cancer. I mean,
Yeah,
I know
exactly.
That's caused the breast cancer. So
Mhm.
you're in that environment. You're already stressed out. You're already like prime candidate
Mhm.
for this
Mhm.
disease. And then what? Then you're right, that none of that really goes away when you get the cancer.
None. If anything, it becomes not your neighborhood, but your place of entrapment. Because to be clear, just because people come from the lower socioeconomic rung, that don't mean they're not aspirational. Most of those people
Say
was
that
trying to get out and go somewhere and move their families and get to a different area anyway. That's clean. That there's well-maintained lighting, all of these things, right? So all of that for the patient, a lot of times, oftentimes disappears, because now they have to shift their focus. So now they feel more trapped, which makes the hopelessness even heavier. Before it was a challenge, but now
Right.
it's a barrier.
Now it's a trap. Now it's a trap.
It's a trap. And the reason why I do focus on the clinical, but part of the reason why I don't make it my central focus is I feel like as long as the focus remains primarily on clinical, the humanity of the patient can get lost. And it's easy to explain away why there's no funding for the clinical, but it's harder to explain why there's no greater effort for the moral. And so I try to keep it morally centered, meaning that you might not have funding for this trial, but do you have funding for this tribulation? Meaning, okay, because
That's a slick one right there. Wait a minute.
Say that again. Say that
You
again.
slid that one in.
okay, please, yeah. Like I said, you may not have funding for the trial, but do you have funding for the tribulation? Period. And Billy, that's a lot of the reason why some patients don't even get involved in clinical trials as much as we would like. Because in the Black community, we ain't never heard the word trial that wasn't associated with a tribulation for the most part, if we're gonna go there.
Hello.
Right? So in hearing the word trial, we're less ready to accept it, because now we're wondering, so what's the tribulation with the trial? What's coming up with this? What will I have worse side effects? Will I have no help? Will there be anyone that's culturally responsive? Will Again, it feeds back into the hopelessness. And so that's the first thing that I really try to address as best I can, is to figure out how and if I can assist the patient in addressing any areas of hopelessness. not as
Mm.
just as they exist, but as they emerge, you know, and because if you can keep somebody, try to keep them hopeful, then it'll help them through their journey, and it reestablishes value oftentimes in themselves, and it keeps them looking forward, and it can help to uplift their whole family if they see that, you know, there's some optimism.
Right. Right.
It lessens the fear so many, because I mean, I don't have to tell you guys how many patients, especially mothers, they try to hide their condition from their children because they don't want them to be afraid. You know, they're trying to
That's
put on
right.
a smile when they really don't even have that much to smile about. If we can figure out a way to really provide them with that hope, at least that part of their journey gets a little easier. Because honestly, I feel like that's one of the hardest parts of the journeys that I've seen, is when their faith and their hope is
Is
like
gone.
severely challenged.
I know. How do you have hope about your cancer
Yep,
if you're worried about where you're going to sleep tonight or how you're going to feed
Yep.
your kids, right? How can you have hope
yep.
if you're already in a state of hopelessness,
Mhm.
get cancer? Then how do you build that on top of it? Wow.
Yeah.
We have to find ways to make hope tangible. And again, that's in a lot of the resourcing. When you can tell your patient, when they come to you, you know, I don't have a place to stay,
Right.
or my rent is due. I'm not working. I'm getting ready to start my treatment, and I won't be able to go to work. And I can point to a resource for a cancer patient as quick as they could point to a resource for COVID. That's hopeful. That's hopeful.
I love that.
Okay.
I've got a couple things that I took away from this, because I took what you said and flipped it on its head. Z. You know, we might be able to fund that trial. We might be able to fund that trial. Farmer got money. We can fund the trial, but can we also help fund that tribulation? And I
Exactly.
think that goes hand in hand.
It
And
does.
you
Right.
know, the other point of it is that we don't realize the amount of bravery it takes to even admit some of the
Right.
things, right? Usually it's in that last 30 seconds when the doctor's got their hand on the doorknob and we're getting ready to walk out of the room, and we might just say two words. We might say, "Is there anything else?"
Mhm.
Or that patient will just say, "One last thing," or "By the way," or "Another thing." And for me, I remember I asked a patient recently, you know, we were getting ready to wrap it up. I said, "Okay, I need you to eat good food and get good rest." And I said, "You
Mhm.
know what that means? And what does that mean to you?" And the daughter said, "Go ahead, tell her, mom." And I said, "Well, tell her what?" And she said, "Well, mom's been losing weight." And I said, "Okay, you know, want to tell me about that? Is it your appetite? Is it something else? You know, tell me more." And she said, "Well, food's really expensive."
Mhm.
God.
And I go to the food bank and I go to the Y, but the food there isn't always great. And sometimes when it's pretty good, I'll try to stretch it for a couple meals, and I'll take the lunch and stretch it to
Mhm.
dinner. And then it all comes out after the diagnosis, after the treat, after everything else.
Everything.
And if you don't wait for it, if you don't pause for that moment, you miss it as a clinician. And
Mhm.
it's so important to make that pause, because it takes a lot of bravery to say, "You know what, I don't have a place to sleep tonight."
Mhm.
Right, to tell a perfect stranger in their white coat, after you just sat there and, you know, all your glory, everything is out, and they told you everything that you need, and to be able to admit, "I don't have food for the night,"
Food tonight.
you
Yeah.
know?
Well, you know,
Yeah.
a couple years ago, I sat on this panel at SABCS that Mema did this great event a couple years ago. It was kind of the first really big Black event at SABCS, and it's a San Antonio Breast Cancer Conference, big conference. And so the panel was me, and I can't even remember the other people, but there's this beautiful, lovely white doctor on the panel. And she was, you know, dressed beautifully, and she was kind of, you could tell she was a little standoffish because she was in this room of Black women, like all these.
Mhm.
And but she said, "Well, you know, I have a navigator in my office. I have a social worker. We have gas cards. We have Whole Foods cards. We have stuff we can give out to people." And I said, "Well, where is it in your office? Like, who's in charge of it?" She's like, "I don't know. Somebody at the front desk knows how to do it." Like, I said, "Well, are patients using them?" And she's like, "Well, frankly, nobody ever asked for them." And I said, "Well, how would they know to ask?" "Well, if you need money or you need gas card, you should just ask for it." And she had no clue what I was talking about. And I said, "So you want me, the little Black woman patient, say, 'I'm poor, I don't have any food. Can I please have a gas card, doctor?' That is not going to happen. And she got so flabbergasted, she actually walked off the panel.
That's
But
crazy.
I started questioning her, like, how could you expect someone, another woman like you who's sick with breast cancer, to be, first of all, to just, you just assume that you have this stuff because you're not telling her anywhere. How would she know, right? And obviously your navigator and your social worker people aren't making it known that they can have these services for you. And you're going to expect the patient to ask for help like that? Like what? WTF.
Yeah.
See,
And
but
if, let's,
go ahead, sweetie. Go
No,
ahead.
I want to bring it around to policy, and I want to bring it around to what legislators should know, but I want you to go ahead and finish your thought, because then we're going to start to talk about a little bit of what American Cancer Society is doing and kind of get into some of the areas for, I think, for what should policymakers know and what should we bring to the Hill about this topic.
I'm sorry, I apologize. You're gonna hear my phone ring in the back.
All good.
But what I would say is that for patient navigation and social work and areas such as those, that might be the position, but their position don't determine the way in which they approach their purpose. This is purposeful work. And when you get stuff like that, that means they're adhering to the position, but they don't have, they haven't heard or quite understand what the purpose is. I'll put it like that. Because at the end of the day, that should all be a part of the intake process anyway. So I don't even understand how you missed that.
Right.
And then it makes you wonder, like, where's the empathy? What ear are you hearing with?
Right. Right.
You know, you got to have a certain ear to hear, so to speak. You don't only hear what the patient says, you listen for what they don't say. You're looking right at them. And you can, a lot of times, you can look in a patient's eyes. And a lot of times you see the fear. A lot of times you sense a question.
You can do that. You can do that. Not everybody can do that. And not
You
everybody.
know, honestly, I've worked and I've had the privilege and the honor of working with some real badasses in terms of navigation. A couple of people, Linda Carter, Cynthia Rowden, just incredible. And I didn't have it either, but I thought I didn't have it, put it like that. But they gave me the freedom and the permission to do this work with my humanity first, to not do it as a navigator first, to do it as somebody who care about these people first, about these patients, about these mothers, you know, do it with that first. And that allowed me to just really open not just my eyes, my ears, but my heart. Like, well, who is this in front of me? And I'm telling you, if we start leading more with our humanity, you start to see it more clearly. Stop looking at just a patient. Stop looking for signs of cancer. You know,
That's powerful.
Look for signs of hopelessness. Look for signs of, you know, questioning, of wondering,
Right,
of hesitancy.
right. Of concern.
Exactly. And
Yeah.
then you bring care to that. Because let me tell you, when somebody know that they care for, that within itself will give them hope. Because they know every time they walk into that office, they're not getting somebody that's sitting there, honey, with their little clipboard, answering a whole bunch of questions, check, 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 check. And then when they look up at you, it's to say, okay, and the doctor will be in a moment. No, that ain't it.
Right.
Right? You start here.
So much, so many thoughts, so many things
So
to
many
say.
things. I know. I'm
So,
trying to-
so when we talk about what policies we should put in place to help support navigators in navigation, what do you think is a good place to start in terms of what legislators can do to make sure that navigation happens for everybody, not just for the people lucky enough to have a Z in their life?
Girl.
Mhm.
Well, first of all, I'd just like to say, for those who may not know, the concept and the first implementation of patient navigation was developed and designed by Dr. Harold P. Freeman, a Black physician out of Harlem. Initially, it
You know
was
that? Did you know that, Mo? I didn't know that.
yeah.
I did. We offer navigation classes and everything, and Dr. Freeman is well known for this work because
Yes.
he recognized the need for it, and he's a pioneer.
Yeah, he's the father of navigation.
When navigation first began, it was as peer-to-peer. And it was centered around, inequity in terms of insurance and other things that were impacting Black cancer patients, Black breast cancer patients. And he developed a navigation as peer-to-peer, no staff, no what have you, and it became super successful. Over the years, we got a navigator for everything. I'm surprised they don't call a president a navigator, okay? Everybody a navigator. But from my perspective, navigation it's segmented differently. I'm gonna use that word today, okay? And when I say that, I mean, like, navigation is recognized primarily as nurse navigation, oncological. Right. Non-clinical navigation got so many different designations, from community health outreach worker to community health worker and personally, and maybe just because that's my profession, it makes me feel a type of way. Because there's a lessening of professional support and recognition when you're giving a lay term for a non-clinical function. Don't call me no lay navigator. I'm not a lay navigator. I'm a non-clinical navigator. And that distinction should be drawn just as a clinical navigator should be drawn, because at the end of the day, if you have navigation for the nurse, they're primarily dealing with helping with pain management and appointments and things like that.
Right.
But when it gets down to the social determinant and those elements, that's the non-clinical part. And as we continue to learn more and more and more about the impact of social determinants on health and on the completion of and adherence of our treatment plans, we find that the social determinants weigh just as heavily, if not outweigh, oftentimes the clinical in terms of accessibility and the barriers. But we're not funded the same. We're not supported the same.
Right.
We are an option. Whereas in the patient's life, we are a necessity. And there's emerging inequity and disparities in the way we are funded, the way we are supported, and the way the programs are grown. And really, they should go hand in hand. They should be along the continuum. There are various types of navigation.
Right.
And the patient should have access to the type of navigation they need for that particular journey. You should have access to an oncological navigator, but you should also have access and be provided with non-clinical navigation, because we're with you throughout the continuum. We're there when you don't have an appointment. We're there when you have additional appointments. I work inside and outside the system. I might be in social services one day, getting ready to, help a patient with an appellate procedure. I might be at radiation at a whole nother facility outside of our facility while they're getting tattooing. I could be a variance of places. So we literally, if done correctly, should be along the journey with the patient from the moment of diagnosis all the way through survivorship.
Everywhere the patient is.
Everywhere the patient goes, but the funding isn't there. So I would think that part of the legislative fix or recommendation that I would make is that there be more specificity inclusion around non-clinical navigation, and not look at navigation as just being solely oncological, or that it be nurses. And also that actually it impacts cultural responsiveness and sensitivity, because most of the nurses are white. Let's just be real. We don't have a lot of Black nurse navigators. I've been doing this work for 11 years, and I have yet to work with a Black nurse navigator.
And isn't it ironic, though, that navigation was started by a Black physician for people who, are the least of these in terms of the accessibility to services. But they now have really been left behind in I'm gonna say in the moonshot. But I think you're right in that we need to do a better job of not singling out a touch point for navigation, but really looking to make it more seamless. So then my next question is, what is the role of the navigator in screening? Because the way we break this up in our American Cancer Society and other places at these meetings, is that there's a role for navigation at screening, at diagnosis, through treatment, into survivorship. And you sort of compartmentalize it that way to better understand where the needs and the resources should be directed. So maybe let's parse it out a little bit and talk about that. What is the role
Yeah.
of a navigator in screening? So before a cancer diagnosis even happens, what should a navigator be doing?
Well, this is where I diverge a bit from that because I'm like, okay, so the way my role is, you don't even get navigation until that diagnosis is definitive.
Until it happens, yeah.
So for me,
So
that's
you
not
know-
navigation in terms of screening, that's community outreach. You should
Okay,
be
say
getting people
more.
to get their screening. Now, if you want to call them community outreach navigation, that's fine, but let's be clear. If
Mhm.
there's no cancer, there's nothing to navigate from my perspective, because I'm a cancer navigator. I'm a breast cancer navigator. So I don't even come in the picture
Your journey begins with the cancer. I got you.
with the
Okay.
cancer diagnosis.
Yep.
But I think that you can have, if you're gonna do cancer screening, that ought to include BRCA testing. It
Mhm.
ought to include a whole lot. There should also be educational component to the screening, meaning that,
Yeah,
you say, okay, explain what a BRCA mutation is. That's part of navigation. Don't you always want to explain to your patient what's going on? Okay.
That's right. That's
So
right.
you want to bring in that educational component.
right.
You want to be in a position to do that warm handoff.
Right.
If you are navigating a patient and they get a screening that is abnormal, immediately they need to contact their breast clinic or whatever clinic they deal with and say, you know what, we have this patient. Because I've had patients that never had cancer, but we kept them under surveillance just because of the
Because
way
of
things
genetics or
may
whatever.
have looked.
right?
So they need to have a surveillance component with screening. If you have a patient that may have had calcifications and you keeping an eye on it for
Right.
whatever reason, then you keep that in that screening navigation. You keep that in that queue and you keep watching, because now you're literally watching to see when
Right.
is their next test,
Right.
Mhm.
what is their imaging. If you're gonna assign navigation to screening, then it should cover
All the
all
things.
their testing. It cannot just be initial. Oh, well, they did a mammogram and I'm a navigator. No,
Well,
I don't believe that, because if it's going to be mammography based or, a singular test, then it's just a test. There's no
Right.
navigation required. They took the test, their
Mhm.
results will take them into the next phase of their care coordination should you need it. But I think they could flesh out the screening and really make it really broad.
I like what you're saying about that, because what ends up happening in the screening paradigms are that, one, we assume that mammography is the end all be all to screening, and there's so much more to screening. Two, it excludes a growing demographic of people who need to be screened in some way, shape, or form, but
Mhm.
don't meet the guidelines. But I do think there is a role to help people navigate the confusing landscape of screening. I think
Mhm.
that part of it, and that, you call it health literacy if you want, you call it whatever, but I think helping people get to screening and get to screen to be screened is a navigational piece that maybe is outside of the realm of the cancer navigator. I agree with you, but I
Mhm.
think that there is a role in early detection for helping people to navigate what's really confusing right now, even to doctors.
It-
Right.
You know,
well, also though, that even the screening thing, it assumes that you're going to get a checkup. Like, to me, maybe the navigator gets in place when you go get your annual gynae checkup and you get a pap smear or whatever, but is everybody even doing that level of care for themselves? Are they going to get annual checkups? If you don't have insurance, I mean,
do
think
they
about
know if it's even annual anymore, Ricky? Like, it's
exactly.
getting so
You
interesting
don't even
right
know
now with
where
it.
it is. Right. You don't even know, but think about how many people don't even, they use the emergency room as their doctor's office.
Mhm, mhm. And that gets into a lot of issues of insurance, like they have the Every Woman Counts program, they have the breast cancer cervical treatment plan, which covers screening and diagnostics. They could educate patients about that. For my populace, we don't have screening navigators, but we do engage in screening outreach and education. Because I think we have, for a lot of my patients, meaning our population, we still have to really always think about the way we approach informing people about cancer, because they get so scared right away. And then sometimes if you talk about them getting screened, and then the worry, I've learned this from so many patients, is what if I have cancer, then what I'm gonna do? Because now they projected beyond the screening, they already planned and worrying about what if I do have it. So that's why the educational piece to me is so important and so critical. And then if you're gonna engage in that screening, make sure you have the resources readily available. Don't screen nobody and don't have nowhere to go. If that screening comes negative,
Hello. What are they gonna do, right?
No, now they stuck. Thank you for giving me another problem. That's their attitude, rightfully so. So we have to make sure that the screening component is comprehensive enough and well-resourced enough that it's not just a screening, it's the screening is the process, but now we're gonna get them into the support, and that is seamless, and you're not just giving them some referral that you don't check up on, you don't know what done happened, blah, blah, blah. Walk them to that front door and introduce them to their navigator or to whatever next process they may be undergoing. Make sure that
Who's the handoff to? Right.
Yeah,
Right. Who's the hand
it's all there.
You're even, how do you even get there though? You know what I mean? If you don't even know that you need to be screened, it's so many pieces to this. But clearly, once you get screened, even just explaining a mammogram, because we have patients call us all the time, too often, and say, well, I got the free mammogram because the truck came to my church or whatever. But I got a funky result and I have to go back to get the MRI or the sonogram, and it costs $2,000. So they don't go. But if they had a navigator in that situation, they would be able to be problem solvers for getting the money for the diagnostic testing that has to follow the screening test. But we hear that so much. Well, I didn't go because I didn't have money, or I could have missed a day of work, or
right. And I think that's a part that can be legislated, and that it can receive that funding, because actually that could almost be considered as part of a preventative measure. And then oftentimes,
like colonoscopy, right?
And then they can get the funding for that, because we have hospitals and we have public health departments that focus in on preventative, where public health doesn't treat, but they do engage in preventative. And even if you house it within a lot of public health agencies, that preventative piece, in which they automatically get that transfer into their care system. You can have a screening navigator be at every last one of those trucks. You can have them there with someone that enrolls patients into the proper Medi-Cal programs, whether it's Every Woman Counts, BCCTP, or just general Medi-Cal. If they don't have Medi-Cal, do their insurance right there. Thank God they don't have cancer, but if they're going to get Medi-Cal, they can still keep up their health. That's still an investment in their health. So you start making the insurance piece a broader piece, or more central piece to screening navigation, and that helps to possibly prevent any fragmentation within the time they get screened to, whether they need or don't need any additional assistance. And then most patients, they're in a healthcare system somewhere, even if they don't go to the doctor regularly. And if not, then you can work with the patient and your health providers to find out where they should be referred to. And get them in there.
Guys, I've been working on this the President's Cancer Panel. I guess connected to Moonshot. I'm not sure how these things are connected, but I'm on a working group for tele navigation. So what do you think about that, See? Like, to do telehealth or telenavigation to reach more people? And, the argument is we can reach more people. They don't have to be connected necessarily to their geographically connected hospital. But we could provide this service and have it mandated by or paid for by the government.
Well, my thing is, are you trying to reach people or are you trying to serve people? Because that's a distinction with a difference. I don't know what store is closest to you in Ohio, but I know what's up in Oakland. It just depends on the type of navigation because it will become geographically based at that point. If a patient is looking for housing, or if a patient
Right.
says, I live on 23rd and I'm trying to get to 55th and I'm not sure how to get there. I'm an Oakland native. I can say, you
Take this bus.
or I can send a lift. Oh, wait a minute, you over there by the, all of
Right.
that kind of stuff, that really helps. And it also makes the patient feel that you're more accessible. Nobody
Mhm.
wants to run the risk of calling a navigator and it feels like a call center. Not to be rude, but you would have to put some type of, you would have to create it in a way in which we don't want to be a replication of a call center from a hospital where we're saying, oh, I see you're here. I think we can do telehealth and I support it, but with some fixes. Make it regional. Make it where it gets down a little bit more into the geographics. And again, I say it like this. Do for cancer patients what you did for COVID patients. We don't got to reinvent the wheel. We just got to invest that same money and time.
Right.
How about
Period.
that? Wow,
You know,
wow.
Right.
Because
Right.
I think there is a role for telehealth to
Mhm.
connect people, one, to folks who don't look like them. You may be in an area and none of your navigators look like you and don't really serve and cater to your specific or your unique needs. But chances are that regional telenavigator might not be able to either, depending
Right.
on where they're calling from.
Right.
And
Mhm.
so some safeguards have to be in place in order to really help to reach people, not just check the boxes, because it ends up being a checkbox. We offered this service. Yep, check, check, check.
Mhm. Mhm.
And like you said, you measuring reach or you measuring impact, because
And then
those
you
are
also
two
have to think
different
about
things.
case management that's associated with it. Patient
Yeah.
navigation got case management. I don't know what people think.
Right.
If we don't just refer you to, the homeless center and we done. If that's the case, somebody is doing it way wrong. Let me just be very clear about that.
Follow up with that.
Patient navigation is case management. Okay. And so you also have to think about how would
I'm writing notes for tomorrow, man.
a non-regionally based telehealth system work for case management? Who are they going to talk to? How are they going to establish the resources? What kind of relationships are they going to be able to establish to
Right.
ensure? And what kind of follow-up will they be able to do
Right.
besides a phone call?
Yeah. Is there even any follow-up? Is there follow-up? Right.
Then that's not, then they need to revise and rethink what the purpose of telehealth is and how that would differ from a patient calling ACS. If all you're doing is giving a resource, then that's not telehealth. That's just giving a resource.
That's a directory, right?
Exactly. And
Right.
those are the type of distinctions that have to be drawn. I just feel like telehealth could definitely be achieved for navigation. And I feel like it's a good idea, but it has to be really fleshed out. And in order for them to establish systems that are equitable, they have to bring equity to the table. Come to us the same way you came to COVID. That's my whole thing. COVID has changed my entire approach and has raised my level of expectation because I see what you can do. I've watched the rapid response. I've seen you lift up the patients with COVID and the economy. I've seen you lift up the mothers, the fathers, and the business owners. So I'm not trying to hear a whole bunch of, oh, well, we can't.
Can't afford it.
Oh, we
You know
tried.
what?
And oh, we're looking at.
I
No,
love
we
it.
looked at that with COVID because remember, everybody
Yeah.
was shocked,
Yeah.
right? Everybody was shocked at COVID and, oh my
Yeah.
God, and all the social determinants and they arose to the occasion so quickly.
Right.
So we're not asking for a reinvention of the
Right.
wheel. We're just asking for four of our own.
Why can't we do that for cancer? Right. If we can do it for
Right.
COVID. Yeah.
It's done. The
Right.
mystery has been solved.
Mm. It's
Right.
resources, it's money.
There are
Look at
resources,
this money, it's putting your money where your mouth is.
you know, and again, that gets to the valuation of the patient, of all cancer patients for that matter, but especially for Black cancer patients and patients of color. You know, there's a different valuation that's assigned to us many times, or
Right.
the devaluation, if we really want to get there.
Right.
And we have to bring intentionality in addressing that when establishing equity, because if we don't, that inequity will always
Always.
remain. It
Oh,
will,
Yeah.
So right, you're so right.
you know, and
Boy.
so we have to bring that to the table, especially in consideration of things like telehealth and this and this and that. Because, okay, so now, do we know that every cancer patient that's poor, do they have access to a phone? Do they have an Obama phone? Y'all still funding that? Oh, you not? Well, you probably need to.
Well, yeah,
Because
the
that's how
phone,
our poorer
Call it
patients
whatever you
have
want. Call it
access.
whatever you want, right?
Right.
Listen.
the bandwidth, the,
Right.
even the
So-
training to use the technology, all
Mhm.
the things. I mean.
So
I
we
mean,
have to address all of that.
all of that stuff, yeah.
Telehealth.
Also, what if you're in a one-bedroom house or a one-room house and you got
Mhm.
kids, and you don't want your kids to know that you're sick? So now you
Mhm.
have no privacy to do,
Mhm.
right?
Mhm.
Or
Mhm.
so,
You
or
know,
you live with too many people in your house, or
or will they get appointment times?
right, or appointment times from 9 to 5.
Exactly.
Not-
Or
yeah,
after hours, because they might have to work 9 to 5, have that boss that won't let them off of work and say, you know what? I'm gonna have to talk to them at 8 o'clock. Will it be Eastern time, Central time, and Pacific time? Like, what are we talking about?
right.
So I would just say, look at the inequities and the system
Right.
fragmentations as they exist in real life, and check to make sure that replication isn't embedded in the telehealth mode, because otherwise it does nothing.
There's nothing. I
It's
know
a system of replication. It won't be a system of service.
Mm.
So
we just launched our Nurse
yeah.
Navigator program and
Yeah.
support some clinical trials, and the calls come after 5 o'clock.
mhm.
Oh, yeah.
The calls are not when the doctor's office open, but the calls when they really need something. And I feel like they almost wait till 5 o'clock to call us because they would rather talk to Val than talk to their doctor in their trial center.
And they
And-
might. You might be right.
And privacy, because
Private.
if you're at work, I've had patients call me from work close to that time. And the reason they'll do that is because they're still at work, but most of all their coworkers are gone.
Right.
So they can have that conversation without whispering.
Right, right. And
You know, and it's the nuances, you know, it's the
Mm.
again, for me, it's just the
Mhm.
humanity of it all.
The
You know,
humanity.
you know, from the cry to the whisper, you know, you
Right,
see it
right,
all.
right,
Mhm.
right. Yeah,
You
wow.
see it all.
We always have a buzzword every time you come on. I don't know if you know this. I don't
We
know if
do.
you recognize this. And
We do.
last time our buzzword was dastardly. If we were playing a drinking game, we would all drink on dastardly. And today the buzzword is humanity.
Humanity.
Because you have
7
mentioned
times.
humanity and recognizing, acknowledging people's humanity, tapping into humanity, whether it's others or ourselves, right?
Acting with
Treating people
humanity.
with humanity. And I think it's a recurring theme and a really appropriate one as you think about navigation, because if you're not centering that humanity, are you really doing a good job in helping anybody navigate anything?
Right.
Right. You know,
Yeah.
and you know, it's a job that, you know, in all seriousness, it keeps you humble. A lot of times it keeps you angry. Just because you see so much, you know, especially the courage and the vulnerabilities of so many of our patients and their families. And then you wonder why there aren't more resources for them. Like I said, I've been on one since they came out with COVID. I don't want to hear no from nobody. That's not acceptable to me. You know, I don't want to hear why you can't. I want to hear how you can, because we know it's possible. You know, even if you have to do it at a more incremental level, that's not the point. You know, don't come talking to me about, you know, we're here to address inequity and you fostering inequity by not sharing the same resources or the same will, not even the same amount of will with our cancer patients. You know, people talk about housing. What we don't talk about is cancer patients actually deserve legislation that provides them their own housing the same way COVID did. And the reason why I say that is we have a lot of places that provide housing, but they will not provide housing to a cancer patient in treatment because of liability concerns. And because it's not a
Tell me more
SNF,
about housing during COVID. Who got housing during COVID?
well, honey, here in the East Bay, we turned the hotels into housing for COVID patients,
Sure did, didn't we?
big time. So I'm just waiting to see who's gonna turn the
That-
hotel
that
into
happened in
housing for
New York.
cancer patients.
That happened in some other cities too, you know.
Mhm.
Yeah, I don't, you wonder how that's, you know, can even happen. I think that, you know, making the COVID comparison is a huge comparison because why did COVID get the attention? Because white people were dying? I don't know.
Because the economy was dying, let's be real. And
Okay,
that goes back to the valuation, because especially when you're dealing with a population that's primarily Black and brown people,
yeah,
they're working class people, white working class, it doesn't matter. We don't hold the same level of value as that business owner who they say, you know, brings in so much tax revenue. But guess what? So does that worker that y'all send into these overpriced stores and
right,
you
right.
know,
You're right. You're so
getting
right.
paid substandard wages, you
Mhm.
know, and a lot of these big corporations, we have tax value too. And you know, it's upsetting to me that my patients, our patients, are lacking so much, and it's economically based. You're making moral decisions with an economic lens. I understand that there's a practicality in that, but there also needs to be a balance.
Right, right,
And
right.
that's why I always go back to what's moral, because
Yeah.
you can explain away anything that's fiscal,
Mm.
right? If you leave it just fiscally based, but you got to get introspective when you're talking about what's moral. And
Right.
I want you to be introspective when you think about the decisions that you make as they impact these people's lives, because they matter. They absolutely matter. And so my goal is to hopefully be able to get hotels and motels transformed for my patients with cancer the same way we did COVID. We'll hope that they can get some type of pay that is beyond them having to be a stage 4 in order to qualify for presumptive disability, same way the COVID patient did. I'm asking for the same thing for my cancer patients. And I feel like we should do that collectively and legislatively, and then let that be the place where we begin to craft policy specific to the cancer patient, because it's already been done. Let the success be our negotiating point. And
Right,
from that
right.
point,
Right,
carve out our own success.
right.
Now let me ask you this, you know, because the question and the comment will arise about how it's not sustainable, right? And they're going to say, well, that was a short-term effort, and you know, COVID, we mobilized resources quickly in order to blah blah blah, crap. What are your comments surrounding the sustainability of these efforts?
Well, I would say if at first you don't succeed, try again. That would be my response. Let's work on sustainability with the cancer patients, and we'll learn from all of your work. And you can talk with us about any fragmentation or new ways in which you think we can achieve sustainability with our cancer patients. That's what I would
Love
say.
it. I love it.
I love that.
I love that. I love that. I hear you. I think, you know, I love what you said, that, you know, it's not about economics. It's
No,
about,
it can't be. I mean, I'm not trying to live in a utopian world and pretend that money don't matter. It
but
should
health is
matter,
way
but
more
it
important than money.
shouldn't
Health.
matter completely. That's my
Right.
only thing. Don't let it
Right.
matter completely. You know, bring
That's
some
why,
balance.
that's why navigation needs to be legislated though, because
Has to be.
if you think
Has
about
to be.
it, too, if we had some more of a breadth of resources that people could rely on as a navigator, that you knew you had at your sort of your tools of engagement, right? And that's universal, that every hospital has or every doctor's office has, then it'll be a different economic situation.
It totally would. And I would just ask that when navigation is legislated, it's just navigated as, it's just brought to the table as navigation, because we can't have the separation, because what'll happen is the professionalized version gets recognized
And well, you
and
know,
the non-clinical does not.
And it does not need to be clinical.
No, it doesn't.
It can,
Quite
it's really-
frankly,
no, it takes a heart. It
first
takes
of all, you got a nurse practitioner that can do the same thing. So let's not play.
Right.
Yep.
Okay, that's a designation without a distinction. It's just in the duties. They're
Right.
both nurses,
Right.
but navigation is different.
Right. Mhm.
It follows the entirety of the continuum when it's implemented properly. And
Right.
it for me, it's almost like you a guide, you a support, you're
An usher.
a warm hand, a heart. You try to be there. It really, to me, navigation is the support of the human condition in that journey.
Yeah,
That's what I would say it is.
I call Val a fairy godmother.
You know?
You know what I mean? She's a fairy godmother because
Mhm.
a lot of the time the patients just need you to hold their hand and talk to them
Mhm. You
before
know.
they talk about chemo. Just hold their
Yep.
hand and say, we're gonna get you through this night
Yep.
and
true.
okay tomorrow. It's getting them through an anxiety.
It's
Getting them
true.
through-
It's true.
And
Yeah.
we can just, continue
all
to
about
push
love.
for it. Because
Right.
like I said, we got to really start looking at what are the luxuries in healthcare and what are the necessities.
Hmm.
Navigation is a necessity. It should not be looked upon as an option
Right.
or a luxury. It's a necessity, and I just think, we can be more bold in the way in which we frame our plight,
Right.
Hmm.
our needs, and
Yep.
bring it in our perspective and
Wow.
the patient's perspective.
Absolutely.
Oh, wow. Well, you gave me I have 2 pages of notes to take to our briefing tomorrow, Mo, about
Yeah.
the role of navigation, how important it is. And I don't think anybody should have to go through any serious health condition without that kind of support. And it's way bigger than the doctor, the nurses,
Wow. Yeah, and the unfortunate thing is some patients don't go through it without that support. That's
Right.
the part they don't talk
Many,
about.
many patients,
You know,
right?
how
More
many
than
patients
should.
stop going
Right.
because they didn't have support?
Right.
What oncological nurse
Right.
gonna come to your house?
Right.
It's true.
Right. Feed your kids.
Mm.
Okay,
Right.
so that part.
Yeah.
I just love you guys. I get to be so myself and just
I can't imagine you're never yourself, girl.
girl, I've been
love it.
trying, but it's kind of been
No.
successful, not really. But I just
You,
want
you
to say
are what's needed. When you walk into the room, you bring all of
Are
you,
the
because
voice.
all of your you-ness is exactly what's needed in any circumstance, in any situation.
well, again, I love you, and I want to just say thank you so much again, and to the listeners out there, just listen to your bodies. That's your greatest barometer. Let that be your screening guideline, and it's not so much about demanding the services or inquiring about the services. Is knowing your self-worth and making sure that you get your respect throughout the process. Because in the absence of a navigator, hold on to your self-respect and your dignity, and make sure that it is addressed and it is embraced at all times.
That's your ultimate
Well,
navigator, isn't it?
Yeah,
Yeah.
that's
Self-worth.
big.
Wow.
Yeah.
I love you for saying that. I do. And I think it's something that everybody needs to hear. That's a bomb. That everything you need is in you.
And you drop the mic. She dropped the mic.
You did. Wow.
I love you guys.
We love you too. We hope it's been
Love you.
relatable and reliable and real, because that's what we do here. Every time Z is on, it's all 3 of those things.
Right.
You guys are so
And
kind.
more and more. She brings it with love and
Yeah.
just lived experience of doing this. This is your heart's work and you could feel it.
Keep doing what you're doing.
Okay, well, ladies, I love you, and I'm be glad to come down there. Hopefully next year I'll be with you guys at the Congressional Black Caucus.
It's a deal. It's a date.
Yeah. It's
Well,
a
I will
date.
insist upon it. Absolutely. You
Yeah.
got it. Yeah, there's a
Yeah.
seat with your name on it. So we're looking forward to it. Well, we have your notes and your thoughts, and hopefully you can tune in tomorrow. And Ricky, I don't know if we can put in the chat how people can watch.
We're
Yes,
gonna
please.
be live, we're gonna be live
Oh.
on this platform.
Oh,
We're gonna
there
be
you
live
go.
here and on the Touch platform. Yeah, we're gonna be live,
Well,
so.
thank you, Black Doctor, for
Yeah.
showcasing live the Congressional Black Caucus Legislative Conference panel on
We're live at 11.
policy and navigation.
All right, well, send me the link, the time, the
Yeah.
links, because I'm out here on the West Coast, and you know, if I can help you, let me know.
We
Love
look
you,
forward to
girl.
it. We'll see you
Yeah.
in the chat, and we'll see you in person sooner than soon.
Okay, sweeties. All right, love
Dr.
you.
Zen, love you
Love you,
too.
Rusty love.
Okay,
Girl. Bye.
bye.
Bye-bye.